So you Nice. Yeah, well, yeah, do the intros if you don't mind, mate. I'd appreciate it, and I'll pick up with them.
Hi everyone. Thanks for joining us today for our online seminar. I'm Dawn. I hope that all of you have your lunch on hand. Today's seminar is hosted by the Centre for Digital Transformation of Health and co-hosted by the School of Computing and Information Systems at the University of Melbourne. This event is also a CHIA CPD endorsed event, and it's worth 1 CPD point. Now it's my pleasure to introduce a wonderful colleague and our speaker for today, Dr. Daniel Capurro. Daniel is a senior lecturer in digital health at the University of Melbourne. He is both a medical doctor and a health informatician, and he'll be telling us more about his work on process mining to improve healthcare delivery.
All right, thank you, Dawn. I'll briefly start my video so you can see how I look, and then I'll just turn it off for the rest of the talk. So first of all, I would like to thank everyone for participating in this seminar. I know that these are complex times, and most of you are, you know, changing teaching and working from home, and all those changes, you know, take time and energy. So again, thank you for being here. Today we'll be talking about process mining in health. And as Dawn said, this is part of the seminar series for the Center for Digital Transformation of Health. It's a partnership between the University of Melbourne, Faculty of Medicine, Dentistry, and Health Sciences, and the School of Computing and Information Systems. So a little bit about me. As Dawn mentioned, I'm a medical doctor, internal medicine specialist. I do not practice here in Australia. I have a PhD in biomedical and health informatics. I was faculty at the Catholic University back in Chile until 2009. I spent a few years as Chief Medical Information Officer for the Academic Healthcare Network at that university. And in June 2009, I joined the University of Melbourne. So for today, this presentation, we will be discussing about health services designs as interventions on themselves, discussing a little bit about healthcare processes, going through the basics of process mining in health, and touch a little bit about a research agenda in this area. So first of all, you know, the current definition of health services research is the one that we have here. And it states that health services research is multidisciplinary field, basic and applied, that studies the use of cost, quality, accessibility, delivery, organization, financing, and outcomes of healthcare services to increase knowledge and understanding of structure, processes, and the effects of health services. One definition that I like more is one that comes from the 1960s that says that health services research seeks to improve the network for providing healthcare so that the fruits of biomedical research are readily available to all citizens. So it's a lot about research translation. So it involves how do we organize the delivery of healthcare so that what we know, what we learn through biomedical research can really reach patients and have a positive outcome, a positive impact on health outcomes. So this is just one example of a study in Australia as a health services design as an intervention. So in this case, the authors, you know, state this problem as that there's a close they want to close the 10-year life expectancy gap between Indigenous and non-Indigenous Australians. That disparity largely driven from cardiovascular diseases and diabetes. So they designed this study where the population is Indigenous Australians. The intervention is co-payment incentives. They compared with no incentives in a before and after study, and the outcome is the overall use of cardiovascular medications. And the results are pretty outstanding in terms that they find a 26 to 109% increase use of cardiovascular medications in patients that have been prescribed these drugs. So again, the idea is that the drug, we already know that it works and it provides benefits, but these are interventions redesigning the healthcare system to improve adherence to these medications. So we're intervening the system, not additional new drugs or new procedures or new whatever. So the first lesson for today is that the way we organize healthcare can impact health outcomes. And the second lesson for today is that processes and process modeling are well-established methods to represent how a system works. And in health, we have broadly two kinds of processes. Business processes, like the diagram on the right, where we describe the steps and resources involved. And on the left, we have clinical guidelines, which is a very special kind of a process where we describe clinical decisions, different actions and tasks that we need to complete so that we make sure that our patients are receiving the best available recommendations. And we know that it's good to follow processes, good to follow guidelines. And following clinical practice guidelines has been over and over associated to better outcomes and better prognosis. However, adherence to clinical guidelines is usually lower than expected. And we're going to see a pretty dramatic example. So as an example, this is a study that measured adherence to recommended tasks while caring for surgical episodes in older adults. And you can see that adherence ranged from 0% in post-op delirium screening to 92% for antibiotic prescriptions, prophylactic antibiotic prescriptions. So a very broad range of adherence to the recommended guidelines in this case. So there's a huge room for improvement, but to improve, we need to be able to measure this, pretty easily and constantly, so we can monitor what's happening and whether things are improving over time or not. But how do we normally measure adherence to processes? And it's usually in the case of healthcare, it's through chart review, okay? Which is resource intensive. It takes time. It takes knowledgeable resources. And so you cannot do it all the time, and it doesn't scale well. So we need, the lesson 3 for this session is that we need better methods to monitor processes. And this is where process mining and business process mining offers a useful approach. So for business process mining, the first assumption is that there's a mismatch between the ideal world and reality. And there you have the Big Mac example, where on the left side, you see the picture of the juicy burger that's advertised, and on the right side is the actual Big Mac that you get. So usually reality doesn't meet necessarily the ideal expectations. So there's a mismatch between the ideal world and reality, and what we think is going to happen is not always true in reality. Just like the example I showed you with the surgical care for older adults, we design a clinical guideline, but what happens in reality, it's not usually what we design. And this is also true, again, for business and healthcare processes. So on the left hand, you see a clinical guideline for managing diabetes. and screening for retinopathy. And on the right side, you can see how this would look like when you take when you model what's really happening in the real world, and you see huge variation and different alternatives to complete the same process. So why does this happen? The first reason is that there are many exceptions, and people that have been working in process modeling using traditional methods, they know that they need to go and not just interview people working on the different processes, but they need to go and observe what's happening in real life, because there are many exceptions, constant exceptions. And usually what people think we should be doing is not what is actually happening in real life. Pretty much, again, like the burger example. And the second one is that even if we have a perfectly modeled process that everybody's following, precisely, those processes tend to change over time. And they change over time because they change intentionally. We introduce variations, we introduce new activities, new people into the process, and that doesn't get documented back into the ideal model that was designed in the first place. Or they can be unintended changes. So maybe people start, having workarounds to address problems with some steps that may take longer, and maybe they want to save time, and they introduce variation that wasn't designed in the first place. So processes change over time, and there's lots of variation. So just as in clinical guidelines, there's a huge investment in creating ideal processes, and sometimes unrelated to reality. And we end up having large collections of dead process models. If you go to maybe any corporation that has modeled their processes, they probably have a process repository. And what happens in reality, sometimes, it's not, doesn't meet what was designed in the first place. So you end up with these collections of dead process models. And the same thing happens, for example, with clinical guidelines. There are hundreds and thousands of clinical guidelines published by different clinical societies around the world. And not all of them, and again, I would say that most of them are not necessarily implemented as they were intended in the first place. So here's how process mining can help address this. So process mining, in a very quick nutshell, you have data coming from enterprise systems. It could be historical data, it could be live data. And by enterprise system, in this case, the most natural source of data for process mining in healthcare would be take information from an electronic health record, again, as a historical data or as a live data feed. And you take this information and put it through process mining algorithms. And the idea is that you should be able to generate actionable process knowledge. And the actionable knowledge can come in different forms. The most straightforward one is a process model. So I take this data and I let the algorithms generate the model that represents what's happening in real life. So how does this work? You would collect a lot of information in the form of event logs. And event logs look something like this, where you have every activity is in a row, and you have the case ID for the first row. So it could be patient ID, for example. The first event is an admission. It has a timestamp. It's performed by the admission clerk, and it has another attribute, which is, in this case, is location at the admission desk. Then you have the second event, surgery, timestamp, resource, and location, operating room, and so on. You have then, the second patient. And when you take these, you can generate what you call traces, which are the series of sequential activities that patient one is undergoing. So that would be the first trace on the top, ASD. So admission, surgery, discharge. And the second patient goes through the second trace and goes, admission, then the ICU ICU, then the general ward, and then the patient is discharged. So this hospitalization process gives you, in this case, 2 traces, and when you have hundreds and thousands of traces, you can abstract and more general models for these processes. So this is what we would call a process model. And from these traces, you can generate, as I said, process models using different notations. For example, in the bottom, for those that are familiar with BPMN, that's a notation to describe how processes unfold. And for example, those X's show different alternative ways that a case might traverse through. And on the right, at the left side, you can see a social network of all the resources or individuals or people that are interacting to provide this service or to execute this process. A second kind of actionable knowledge is measuring performance. So how well are we conducting this process? So here you can see in this very simple case from an emergency department, you can see that it starts with an ER registration, and then there's they take about 10 minutes in average. Then you have 2 different options. You can have regular ER triage, or you can have a sepsis triage. Then the patient is given IV fluids. Then somebody performs C-reactive protein, and so on. But you can see that there's this node that plays a central role for everyone. Patients in the ER sepsis triage are taking 1.3 hours to go to that node, but you see that all patients go through that node. So maybe repositioning that node at a different stage of the process might help you streamline this process and save time, for example, in this 1.3 hours and so on. So you can see that there's some sort of bottleneck that you can see. In this other example, you can see how we are able to replay history on top of the discovered model. Each circle that you see is a case or a patient as they move along the process. And you can see that there are stages. So here in the middle, you're seeing an accumulation of patients over time moving from one place, one node of the process to another node of the process. And those can signal that you have maybe a bottleneck. Maybe in the future, adding additional resources might help you unclog that section of the process, and so on. A third use, or a third kind of actionable process knowledge, is to measure conformance, and conformance against an ideal process. So I model the process, like the first case we saw here. I model the process as it is happening in reality, and then I can check whether that model or any individual execution of the process, how much is it similar to the ideally designed process. And I'm gonna show you an example in healthcare. So in this study, it was published at the end of 2019. Investigators generated through expert consultation an ideal process for intubating pediatric patients in the emergency department. Okay, so these are patients that are severely compromised, and they need rapid intubation to secure their airways. And then what they did in this case, they were recording videos of the emergency room where these activities happened, and then they were able to annotate those videos, and they generated the real processes, how they unfolded in real life. So here, following the same example as we showed you in this mock set of traces, here you can see every trace of every patient that they generated, and you can see how the activities align. So for example, most patients go through this P, which is the paralytic medications, but not all of the patients go through the same series of activities. So then they analyze and compare processes between those with and without complications. So that's one kind of an analysis that they could do. So here at the top, you can see the model of traces of patients that did not have adverse events. The bottom, you can see those patients that did have adverse events, and you can quickly see that there's a couple of nodes, this N node, B node, and I nodes that were different in these two populations. And they also generated, again, conformance checking metrics where they can quantify how much does an individual trace, like this one, how much does any individual trace align to the ideal process, which is what we were generating here. And they were able to demonstrate that when a trace aligned better with the ideal model, then the chances of having an adverse event were reduced, okay? This is and this is another kind of actionable process knowledge that you can generate, different root causes, like the one that I mentioned just now, with the different nodes that are present in one type of outcomes and not present in another type of outcome. And you can also do predictions. Try to predict which is the node that's going to come next in a process. Say, for example, you're receiving live feed data and you have one patient that you can locate in which section of the process they're at right now. So you can predict what's the node that's going to come next, and then what's maybe what time it's going to take to execute the next node in the process. This is some images from another study conducted by the process mining group at the University of Melbourne School of Computing and Information Systems. They have a very active and influential process mining group, and they compared discharged patient in a Melbourne hospital, and they modeled the processes for patients that were readmitted within 30 days, which is an undesirable outcome, and patients that were not readmitted. And then you can see that these node E was present in those patients that were readmitted. So then it's easier to go and take a look at what's that E representing. Are there activities that we're doing maybe in excess or someone else is doing, or are they happening in the wrong place, or so on. This diagram is from a study that I was part in back in Chile. We modeled the interactions, so the social network component between healthcare professionals. And here you can see that and how they interacted while caring for patients with diabetes. And here you can see that there are different types of patterns of collaboration. At the top, you can see models with 3 nodes, where a physician, that's the P, a dietitian, the D, and nurses, the N, were interacting while they were seeing a patient over time. Each line of those represents a referral. The more the individual participates in the process, the more intense the red color is, and the more referrals that happen in one direction, the more intense the red arrow is. So you can see models with 3 nodes that collaborate more on the left side and less on the right side. You can also see models with 2 nodes and models with 1 node. For example, here in model K at the bottom, you can see that there were some patients where the only professional participating in their care was a physician, and there was no nurse, no dietitian involved in their care. And the physician and the doctor in this case would self-refer the patient over time, and they were only ones doing the follow-up. And we were able to demonstrate an association between more collaborative models, this is models A's, B's, or C's, with better glucose control over time. So this is, again, associating with outcomes, okay? Just like in the example with pediatric intubations, that was the more the process conformed to recommended guidelines, the better outcomes for patients. In this case, the more clinicians collaborate, then the better we are likely to see better outcomes in this group of patients. And again, these are not causal studies; they're association studies. So it's a tool that allows, process mining is a tool that allows us to build these models pretty quickly. Currently, for example, most instruments designed to measure collaboration between healthcare providers are based on surveys or structured interviews, which is something that doesn't scale very well. If you have a huge hospital or a huge healthcare network, then it's hard to understand how everybody is collaborating, quickly. But with process mining, we probably have methods that can help us understand those attributes of healthcare, like collaboration, in a better and quicker way. So process mining generates a new window into analyzing healthcare data, to understanding how processes unfold in real life, and how to understand how each one of those activities and participants in those activities can influence the outcomes of the different processes. And we have better and quicker ways to actually measure all these different processes. And if we think of the current healthcare quality model, where every healthcare quality activity can be classified as a structural measure or a process measure and then an outcome measure, we understand that there's a continuum from a structural intervention and process changes that generate impact into patient outcomes. If we have better ways of measuring how processes change over time, we might have a better way to understand how different structural measures can translate or should translate into improved patient outcomes. So again, this, so the lesson 4 for this session today is that process mining is a useful tool for health services research for the reasons that we covered here. And now moving a little bit, just touching the surface of a possible research agenda for the future, is that process mining in healthcare is a rather new area. It hasn't been around for that long, and most of the research is around use cases and demonstrating different types of uses and different possibilities, but it hasn't been systematically included in daily operations in healthcare. So I'll just mention a few areas of research that are worth exploring. So here on the left side, we can see areas where health might influence process mining research in itself. So for example, when we measure conformance checking, we usually get a number between 0 and 1 on that tells us how similar the process, one individual process, is to the recommended process of the process model. And what influences that number is, are there nodes missing? Maybe there are additional nodes. Maybe there are nodes that happen in different orders. And most studies in conformance checking use cases like call centers or processing of insurance claims, or mostly business cases. But in healthcare, there's some events are, it's critical that some events happen in the right order. So if you do the surgery before giving the anesthesia, then you have a major problem, and that might not be as significant. in other areas, like a call center, for example. That's just a blunt example. But a question is, should conformance checking be different in healthcare? Should we study different ways of measuring conformance, or different ways of weighting the different roles of different activities or actors? Then how do you systematically translate these findings into regular operations of healthcare systems? We still don't have a clear idea what's the best way to present the results to clinicians, to administrators, to decision makers. And thus providing feedback to, for example, individual clinicians change behaviors. If I tell, if I go back to this image, if I tell a clinician, you know, you're behaving like doctors here in the Model K, and, you know, this might be detrimental for your patients, does that change behavior? Does providing feedback change behavior? Or do we need to, you know, give some other information to clinicians? And then new health applications, how processes can be associated with better outcomes. I showed you a couple of examples. Then how do you could use this to detect bias in treatment allocation. We're using a publicly available data set to understand what are the patterns of prescription of pain medications when you compare female and male patients. There's some evidence from previous studies that show that different patients, you know, get different prescriptions based on gender or race, and maybe those difference is in the, you know, proportion of patients that receive certain medications, but we might see different, more subtle differences affecting the, you know, the order or how early different medications are prescribed in different conditions. We could use this to measure intentional and unintentional process changes over time. For example, when you have when you have, for example, a new clinical guideline, you would expect that the process changes, you know, ideally very quickly, but we don't know how fast this new innovation in the form of a new clinical guideline is diffusing into, you know, the real world. So you could model the process over time and see where the changes are happening. That's an example of another potential use of process mining in healthcare. So as summary of what we've been discussing here, and are the main lessons that we discussed. The way we organize healthcare system can impact patient outcomes. There's evidence about that. Processes are well-established methods to represent how the healthcare system works, both in the form of clinical practice guidelines or just regular business processes. And processes are a key component of quality improvement measures, and a key component of understanding how a healthcare system works, but we don't have methods to measure that very quickly in a scalable way. And that's something that process mining could do. And process mining is a valuable tool for health services research. And it's an area that's, again, fairly new in healthcare. So it's very, I feel it's very open for innovation and new uses that we can come up for these kind of tools as ways to understand how the organization of the healthcare system impacts patient outcomes and how can we modify that. So with that, I conclude my presentation. Thank you a lot again for taking the time to be present here. I'm happy to take any questions, and there's my email address. If you come up with a question later on, just shoot me an email and I'd be happy to discuss all the different options. Here I already received one question, and the question is, did you undertake process mapping mining where patients had multiple diseases like diabetes, cardio, and chronic kidney disease? In the example that I showed you, no, it was a very, again, that's a case study, so we selected a very narrow subset of patients that had diabetes, but had no other comorbidities. And so the process analysis would have to change. You would have to maybe generate subcohorts, or maybe you would have to adjust the results based on the presence of these other attributes. So for example, the final analysis could be done with a regression, and then the type of processes like these A, B, C, D to K that I showed you, they could be another variable that influences patient outcome, and comorbidities could be other variables. Another question from Cecily Gilbert is, can you outline the barriers to wider use of BPM in clinical settings? I would say that the first barrier, I think it's awareness. Most, hospitals and healthcare systems are not aware of these systems. The second one is there's a iterative process where we need to understand, I showed you all the models when they look all nice, but sometimes, understanding whether an activity happened, like for example, a medication was prescribed and who prescribed it, you have same issues around data quality and how you represent those activities in the database. Like right now, we're working in a pilot study with the Austin Hospital to look at the discharge process. And the first activity was to look at their ideal model for the discharge process. And then for every node in that process, we interviewed the electronic health record experts in the hospital to see what activity in the EMR was automatically documented or recorded in the database that could reflect each one of those nodes. And some of those nodes were well represented in the database, but some of those were not. Like for example, the first node was the decision to discharge a patient. Okay, and then the doctor would communicate with the nursing team to let them know that this has happened. Okay, but that was verbally done, so there was no actual recording in the database about the moment where the decision is made. Okay, so representing, finding what facts in the database represent actions in the real world, that's one thing that is usually something that takes some time figuring out. Another question from Karen Verspoor. Can you comment on the capacity of BPM to scale to more fine-grained processes with large variability between individual cases? That's a interesting question. I think today, at least in my personal experience, we've only done it again in these very small scale, very well curated examples in clinical care. And one thing is that the distance between what happens in reality and what the process model shows you seems to be very large. So that translation between the granularity and the general case, it's still a hard translation. I don't know if I answer your question. I think we still need to figure out better ways to bridge that gap. And Marcelo here, he's the local expert in process mining, and he says, in my experience, the main challenge to apply process mining in healthcare setting is the cultural barrier of the clinical staff to accept the results of the analysis and take remedial actions accordingly. do you have any practical tips on how these cultural barriers could be overcome? I think so. I learned about process mining from as a clinician from people and in computer science that were doing that work, and it took me, I think, quite a while to understand what were the potential benefits of this. So I think that involving clinicians from the very beginning might be useful. I think especially involving healthcare leadership might be useful to overcome this cultural barrier. But again, I think that usually when clinicians are monitored externally, that feels like an invasion of their professional workspace. And if it comes too externally, that can be negatively received. So I think that trying to do it from the inside might be an interesting approach. Okay, lots of questions coming in. Okay, are these studies usually done in one hospital or service? Is it feasible or useful to do studies with multiple hospitals, or to do disparate electronic systems make it too difficult? I would say that disparate electronic systems does make it difficult. When you have administrative data, that makes it a little bit easier because some administrative data is common to all different settings, like again, an admission, a discharge. Those are things that happen everywhere. Sometimes, document. So there's probably going to be a lot of data manipulation and wrangling to get your logs to look the way you need them to look, to be able to take information and aggregate information across different sites. Okay, another question. What kind of technical skills do you need to run an analysis like this? I think that there's different ways of doing this. So there are tools. I'm not like an expert in the actual, mathematic algorithms that are used to generate these process models. I understand what they do. So that's, I'm not the person with the deepest technical skills, but there's some tools that are available. There are a few good open source tools available. And one of those tools is was developed by Marcello, that's listening here to this conversation. It's called Abromore, and this tool is I've used it with my students last semester, and they were students that had never done it before, and they could take a case log that I provided them. They turned it into what they needed to, what the log needed to look like, and they were able to generate process models and understand basic questions. So I think that with the right tools and understanding how it works, you can solve probably baseline questions. If you have more complex questions, you probably need to start working with Marcello and to understand what are the specific requirements of your analysis. Let's see. So this is Wendy Chapman. Are there plans to incorporate information from clinical notes into process mining methods? I haven't seen that in the past, but as long as you can take notes, activities from the clinical notes and turn that into an action with a timestamp, then you should be able to incorporate those into process mining methods. I know that there's been work done by the NLP group at the University of Columbia trying to extract temporal components from free text in clinical notes. That probably could be a good input for these kind of an analysis. Okay. Oh yeah, Martello answered that as well. Oh, I'm sorry, I didn't catch the name of the tool you said Martello developed. It's called Apromore, APROMORE, um, and I think it's a great tool. Yeah, Don already wrote that in the chat. Artem has another question. So can you explain further some particularities of conformance checking in healthcare scenarios? Any requirements you have already identified? We're in the process of, we're working on a systematic review of guideline deviation metrics. So we're right now going through the screening through all the different studies, but from that systematic review, we should generate what are, in the past, what have clinicians used to measure deviations from clinical processes in the form of clinical guidelines, and that should give us a broad understanding of what are the conformance checking requirements in healthcare. So we haven't identified any one in particular right now because we're just starting the process of that particular study. And Artem is also one of the local experts in developing the fundamental aspects of process mining. All right, Kathleen Gray asks, what are the legal and ethical considerations for health services in doing this kind of research? Is ethical approval onerous? So two things. One thing is, if you're doing this, for research purposes, you need to go through all the, standard ethical approvals. So I think it's not different from any other study using electronic health record data. Other studies might be more complex. For example, the study that I showed you about pediatric intubations, they were video recording the emergency room where very severe patients were usually admitted. So that's, images of patients in very dire situations. So that's probably, that it was done in a context of a broader study that they were looking at, team management of these very severe patients. And this was a side study, but that study would have to take, extreme precautions on how it probably is impossible to obtain consent at that time, but it's very important to make sure that the patient privacy is maintained very, very strictly. The other type of use is, not necessary research, but day-to-day operations. I think we're still not at that point. Maybe Martello has other better examples, but I don't think hospitals are routinely using this into their daily operations. But I think it shouldn't be different from what normal business intelligence happens inside a healthcare organization when you try to understand what are your quality metrics, how well you're doing your activities, how efficient is your operating room management, and so on. I think that this is just a different perspective. So it shouldn't be, I think from the ethical perspective, this is just another way of organizing another way of organizing or looking at data, another way of analyzing data. So it shouldn't be any different than other analytic techniques. Okay, and Marcello says, unfortunately not. This is mostly the effort of researchers trying to push process mining using healthcare. So there's a future. I think there's a future. We need to keep pushing different examples and innovative perspectives and being able to use process mining to unearth different aspects of processes that might influence patient care. So Maya has a question and I think it has multiple parts. I'm trying to, opinions seem to be divided about value of using structured versus unstructured clinical data for deep learning models. What are your thoughts? My question refers to the content in the data rather than heterogeneity challenges. Okay, so there have been some studies. So as a clinician, I believe that there's deep meaning hidden in clinical notes, in unstructured data. So I think that there's great value there. And there's some studies showing, actually there's a study that Karen shared with us a few weeks ago, and they were comparing how, well did the data predict, any specific outcome, and the content that was available as unstructured was way richer and was more powerful in predicting outcomes. But I think it's always going to be a balance on how much effort it takes to extract that information. And there are other ways of complementing that. So I think ideally we should be able to use both structured and unstructured data for all these advanced analytic methods, because probably that's going to give us the best picture of what's happening. Okay, I think there are no more questions. Any last question from the audience? And again, thanks so much. There's so many interesting questions and so much interest from the audience.
Okay, if no one has any other questions, thank you, Daniel, for such an interesting talk on methods and tools we use to understand the processes in healthcare to improve outcomes. Just to mention that our next online seminar is on Thursday, the 23rd of April at this same time, 12 to 1 p.m. And it will be about co-design living labs, a model for lived experience participation. And this seminar will be given by Dr. Vicky Palmer. We'll be circulating another flyer for this in the next week. All right, thank you, everyone.
Thank you. Thanks, Daniel.
Thank you.
Cheers, thanks.
Bye, thank you.